But I want to kind of move on so that we have time for everyone and go into our next controversial topic about pancreatic injury management. I'm just going to learn from my last experience that I'm going to introduce both Sean and Bindi at the same time, and then let them decide who goes first. So we get it out of the way. So first is Bindi Naik Mathoria. She's a pediatric surgeon at Texas Children's and the director of the trauma program down there. She has a special interest in pediatric pancreatic trauma, among other things, and we welcome her to the group in the afternoon. And our other speaker is Sean St. Peter. He's professor of pediatric surgery in Kansas City Children's Mercy. Sean's a prolific writer and prolific presenter with over 270 papers, probably more than everyone on the panel here combined. And he's going to talk to us about the operative side of managing pediatric trauma. So I don't know if you guys had a choice of who's. We'll go with Bindi first, so Sean can get online here. So Bindi, you're on.
Okay. So Rich wanted us to do this in some sort of debate format. We have not pre-rehearsed this, so forgive us if it's not perfect. But I'm going to be talking a little bit about the non-operative management for pancreatic injuries. So this is a kid who I actually just took care of a couple of weeks ago, and he had a bike handle accident. He's a little 6-year-old, otherwise totally healthy, skinny kid. And he came in with this single injury right here. You can see the laceration to the pancreas, you know, in the usual place where we usually see it, just overlying the body of the spine. And there's a little bit of free fluid around there. He was clinically well. He had a little bit of tenderness. And his lipase, I believe, was in the his amylase was in the 700s. His lipase was in the 100s. So let's take a poll. Which management strategy would you prefer for this injury? Distal pancreatectomy. He had just had this injury happen 6 hours before. So distal pancreatectomy, observation alone, or could you go either way? Are we going to do this on the chat, or?
Yeah, we're going to the chat. I'll let Dr. Petty answer, since he seems to know more about pancreatic trauma than I do.
Yeah, I don't know about that. I think I would probably favor an ERCP, and if there's a duct injury, my bias is towards operative management, but I'm willing to acknowledge that that's a bias and perhaps not purely evidence-based.
Okay. Yeah, and what would the ERCP be for diagnosis or for?
Yeah, to see if there's an injury to the main pancreatic duct.
So you wouldn't try to stent, or just to clarify for everyone, you wouldn't try to stent or do any therapeutic interventions.
Let me respond to that. So we have tried stenting, and I would not do it again. The reason is logistically, they came in. They put it on the schedule the next day. They tried. They failed. Then now you're looking at 2 days later, and now you're going in. It's all saponified. So for me, I haven't found the way to do it without it sort of delaying care. I think you need to make a decision if you're going to operate or not. And if I just haven't had great success with the stenting deal.
So I would chime in as well. I mean, I think we actually have had success with stenting, which is why this topic I think is so controversial, because I think you do need, it's all bias, right? That's why we're talking about it. But I think you do need to have some sense of whether that duct's injured or not to help you decide whether they need an operation. And if it's a minor injury, when they do the ERCP, putting a stent in has helped us, and we've had success in non-operative management. I do appreciate it, and I've had it recently, just this past summer, a case where we had exactly what you're describing. We had delayed information about the pancreatic duct. By the time we knew it, we were too far gone to want to go in and operate, and it delayed our operation for several weeks before we felt safe. So there is absolutely that risk on both ends, and I think that's the challenge, is figuring out which of the kids are the right choice. I think operative and non-operative have their place, just figuring out those kids, and that's what Sean and Bindi are going to tell us how to do it.
Tell us the right answer.
So we chose to get an MRCP because CT is really not good enough to tell whether the duct is injured. If you, I think a couple of slides later, have the AAC grading scale, but they actually require the radiologist to decide whether or not the duct is injured, to call that a grade 3. But if you talk to a lot of radiologists, it's really difficult for them to tell whether this is hematoma, ischemia, where's the duct in here. It's just hard to tell. So ERCP is definitely an option, although it does require general anesthetic. It has its risks. We chose to get an MRCP, which although it's never been proven, a lot of people believe that it's slightly shows slightly better delineation of the duct. In this case, it did not actually for us. You can see that the laceration right here, and really could not see the duct. I think just it was a small duct, small child. But what was interesting is that this MRCP, by the time it was obtained, was I think like 18 hours after the injury, and there was very little free fluid there. So I guess our thought process was that even if there is a duct injury, it's not leaking out, a lot, and the kid was doing clinically really, really well. So we decided just to observe him. However, on hospital day 2, his lipase comes back greater than 10,000. So then you're kicking yourself, oh, should I just have operated on him? And really, if you go to the data, there's just not good enough data and it's hard to talk to the parents about this too, because you're telling them, really, I'm not sure what's going to be the best thing to do, and it's hard to ask them to make the decision. So his lipase was greater than 10,000. We debated ERCP at this point. I guess we've already kind of talked about this question a little bit. It sounds like in some places it has. We have not had much success with it, similar to I think what Todd was saying. We've done ERCPs, but passing a stent through the actual injury is really difficult. There's a lot of distortion. If the duct is completely transected, it's hard for them to get it through. I guess if one side of it is still intact, then they can get a wire across. And then doing just a stent at the center of OD is debatable whether or not that actually does decrease the back pressure as it does for biliary injuries. I don't think that's ever been shown. Plus, it could actually worsen pancreatitis. You could get a duodenal injury, et cetera, et cetera. So we decided just to stick with a pure non-operative observation round and leave the kid alone. And amazingly, by the next day, his lipase went down, his amylase went down, and he was doing great. He went home in actually 4 days and did amazingly well. I think we may have just got lucky with this one, but it just goes to show that we really don't know the best way to manage these injuries. So talking about non-operative management, the data, the first paper on this was in the 1980s by the group from Toronto, and they described 11 kids. And there's been a lot of case series mostly out there of people describing successful stories with non-operative management. This is the gradient scale I was talking about. I showed this at the PTS meeting recently, which I think a lot of you guys were at, but this is a summary of the largest multi-center. So there's been several multi-center trials that are studies that are retrospective. And because this is such a rare injury, and you can see the numbers, the problem is a lot of them included children with lower grade injuries that didn't have duct injuries, and comparing those outcomes, adding those outcomes in makes the data a little bit muddy. And then the results are they're kind of all over the place. Some of them show no difference. Some of them show, most of them show higher pseudocyst formation with non-operative management. But besides that, there are a lot of differences in these outcomes. So the main complication of non-operative management is pseudocyst. That just makes sense. If you do nothing, it's the fluid is going to collect there, and it may form into a pseudocyst. We recently did a systematic review and a meta-analysis, which is not published yet, but we combined the results from 24 studies, and looking at it, we found 318 patients with non-operative management and 716 with operative management, and pseudocyst was reported in about half the patients with non-operative management and much less with operative management. And this was statistically significant. And when you did the meta-analysis, it was the only outcome from all the other outcomes that we looked at that actually, was statistically significant. So fistula was actually the same, and all the others, the data was just so different, and there was, it just wasn't consistent enough to do meta-analysis on the other outcomes because of the nature of the data. But there's no doubt pseudocysts are more. But the definition of pseudocyst is also not clearly defined in a lot of these papers. And some people might be calling a peripancreatic fluid collection at day 3 a pseudocyst, whereas others may be calling a pseudocyst at something at a persistent fluid collection at 4 weeks. Only the most recent study, Sean's study, actually defined pseudocyst. So I think that just the fact that you have a pseudocyst is not necessarily a bad thing. You have a pseudocyst, so what? Is that a reason not to operate? Or is that a reason to operate? I don't think we know that yet. This is the data from 19 centers, also presented at the PTS meeting recently, and we asked people what they do with these patients with non-operative management, and you can see that it's really all over the map. Some people are keeping patients NPO until their labs are normal, until their tenderness improves, until both, until either. Regarding pseudocyst, I guess most of us agreed that you did not have to keep the patient's NPO until the pseudocyst resolved. Some people are doing NJ feeds, some people are doing TPN, some people are doing early ERCP, some people are percutaneously draining. We actually have had success with this, directly doing a percutaneous drain of the pseudocyst, and even some kids even go home with this drain eating, and it amazingly closes and doesn't cause a fistula, at least in the 10 cases that we've used it for in the last 10 years or so. And then regarding pseudocyst, at that point, do you get an ERCP and do you try to stent at that point? So I think the bottom line is that there's a lot of variability in this. Our data is just not good enough, the data that we have so far. We're really not sure what the best way to manage these kids is, but non-operative management, if you choose to use that, is safe and it's well accepted. For those injuries, for low-grade injuries and for those involving the pancreatic head. But when you look at grade 3 injuries involving the body, the handlebar injuries that we commonly see, it's controversial, but it is acceptable. Pseudocyst formation is common, and clinical strategies vary. So combined outcomes are difficult to evaluate. So we're actually doing a large multi-center study now where we're going to be combining our outcomes on this, and then the future plan is to do a prospective trial to really study the differences. That's all I had. Thank you.
That was great. That was great, Brindy. I think Sean's joined us now. We'll have Sean give his presentation, and then we'll save a little time for discussion. I know everyone, we're running a bit behind, but we have some cushion time at the end to get everyone done. So Sean, thanks for being here.
Yeah, can you hear me okay?
We can.
All right. I'm going to be able to make up a little bit of time here, as opposed to taking a strong side about the necessity for operation or being an advocate that's better. I'm also just going to go through data like Bindi did to talk about what this involves. So starting with the polling question, and what's nice about both of these questions is they don't have an answer, but it just at least provides food for thought before we go through the rest of it. So 10-year-old goes off the handlebars. CT shows an isolated pancreatic laceration. Appears the duct's injured. It seems that the dark spot on the CT goes all the way through. And so got admitted late at night. Next morning, of course, they're tender. Enzymes are high. So what do you do here? MRCP to make a decision, ERCP, distal panc, or plan observation, regardless of what you find. And so at this point, I think my answer would probably be C, based on our experience here.
Sean?
Yeah.
Do you have slides?
I do. I'm looking at them.
Can you share your screen? You are very handsome, but we also want to see your slides.
All right. Let me find share screen.
It's at the bottom of the screen.
Got it.
And by the way, while you're doing that, the answers so far have been A, B, and C. So I don't think we have much agreement on the answer here.
Beautiful. So
we still don't see them.
So now you can see it?
Yep. Just do share. Yep, there you go. Awesome.
So I expected the answers to be all over the shop on that one. And now we say, let's just for the sake of argument say it's pretty clearly separated. There's an obvious hematoma that separates the two ends. There's no chance that there's just ductal continuity. So you're planning a distal pancreatectomy. And if you're going to do that, would you do it laparoscopic, open, or would you still plan observation regardless of how bad the injury is? This is a stable patient without concomitant injuries.
Sean, how do you know the duct is truly transected?
Exactly.
Right?
Exactly. That's leads to this whole argument. I probably should have just went ahead and said you got it in MRCP and it shows that there's a ductal transection. But even then, it still leads to the same point. Are you going to be of the camp that you're going to observe it no matter what, or try an ERCP stent? But let's say, for the sake of argument, you're going to take it out, and would you do that open or would you do it laparoscopic? And what are the answers looking like there?
So you got a wide range. I said laparoscopic, but you have people saying both. Some say at least to start laparoscopic. Especially, by the way, if you don't even know, this may just be not a duct transection, and you could lay drains, and then you didn't have to do a laparotomy.
Yeah. So that's what we get to is trying to define the difference between 2 and 3. So 1 is a minor contusion or laceration. 3 is a major contusion or laceration. It takes a ramp up once there's a ductal injury. That's where you have a grade 3. Discerning between grade 2 and 3, as you allude to, is difficult on CT. You're going to have some volume averaging through the area of hematoma in the center of the pancreas, and you don't know for sure that duct has been injured, which leads to the higher level of imaging if you want to try to discern between the two. And then, of course, the high grade or the proximal injuries, which are difficult to deal with no matter what you're doing. So we know why we have respect for the pancreas, because it doesn't always treat us friendly. The question is whether we leave an injury alone, do we make the pancreas more angry than if we just operate on it? To review some other data that directly compares operation versus observation, there was a retrospective study from one center with 14 that went to the OR, and they found exactly what you would expect from the meta-analysis that Bindi went through, since all of the studies are in there, I'm sure. There were fewer pseudocysts by doing an operation. And then the multi-center registry data that Dave Mooney published included 43 patients, 23 of which went to the operating room. And again, there was more pseudocysts with non-operative management. Both studies found similar length of stay with small numbers. And so we put together a multi-center retrospective data collection where we wanted to follow their entire hospital course and get all of their readmissions and follow their time to complete resolution when they were no longer needing medical care. They weren't coming back to clinic, they weren't calling for pain meds, and they were all settled out. And we took those that were grade 2 and 3 for a lot of the reasons we mentioned, especially because this data went back up to 10 years, so there wasn't as much of the MRCP use in all of these studies, and of course excluded those that weren't blunt injury. There were 13 centers involved, and we ended up with 57 that underwent resection compared to 95 that underwent non-operative management. And the demographics were similar, except for more grade injuries. Grade 3 injuries were in the resection group, as you'd expect. Retrospective study, patients were treated for a reason, so surgeons were more likely to do an operation if they were convinced it was a grade 3 injury. And when I say grade 3 injury, that's not based on definitive imaging. That's based on the best imaging that was documented at the time. So a lot of these are CT diagnoses. Looking at the outcomes, this is just to look at the relative role for operative drainage. We see that the drainage doesn't outperform resection or non-operative management in any category, but it seems to stand out in a couple of areas. With the initial length of stay and the total length of stay, there were a few dramatic patients that had a protracted course that changed those outcomes. And then it didn't outperform non-operative management with pseudocysts or reintervention, but the total time to resolution was also a lot higher in those that had a drain. So when we were doing this comparison, even though we only had 15 patients, it didn't appear that there was a strong argument to bring operative drainage back into the conversation, unless you were technically in a position that you couldn't do an operation at the time of operation. So in the operative versus non-operative management, direct comparison, this is grade 2s and 3s all put together. There was a quicker time to initial feeds and goal feeds in those who underwent resection. And there was, as expected, a much higher pseudocyst rate in those who underwent non-operative management. And that translated into more reinterventions for those with the non-operative management and a longer time to complete resolution and being signed off for medical care. If we took just the grade 3 injuries, or at least as best proven by the medical record, then we do see those with resection were fed earlier and they went to goal feeds earlier. Now, of course, this is a big difference between a patient-defined outcome and a physician-defined outcome, because as Bindi was showing with the practice management variation, these patients didn't go on to 12 days before they started feeds because they couldn't eat. It was because they were treated that way. And likely their time to goal feeds was influenced the same way, that was probably a bigger influence of how they were managed as opposed to how they could have been managed. But just the same, that ended up creating some of the differences we see down the road, like total length of stay favor early operation. And then, of course, the pseudocyst rate was higher with those with non-operative management, but it was pretty dramatic when we had those with the ductal injury. So it kind of echoes what has been said so far. that when you do have documentation of a ductal injury, then the stakes for doing an operation or getting a stent across it go up, and the likelihood of success with non-operative management without having a pretty major problem go down. Now, that's all depending on how we want to define a problematic pseudocyst. So if we have a patient like Bindi just presented that has a pseudocyst and you put it in a drain and they do well with it, then you kind of get away with it. But we've all seen that patient that ends up 3 months later on NJ feeds and still has chronic pain and has an ongoing pseudocyst and is in a lot of misery. The reintervention rate was also a lot higher in those patients with ductal injury who underwent non-operative management, and the total time to resolution wasn't even close, but that's, again, because there was a handful of patients with quite protracted courses. So in conclusion of these comparisons, it appears that non-operative management results in a higher pseudocyst rate with higher reintervention rate and longer time to resolution. And resection, they get to earlier feeding, but that's likely position driven. And a main duct injury increases the risk for pseudocyst, particularly with a prolonged course compared to resection. And so that's where, particularly in our current state, getting more definite imaging to define the duct is probably prudent in most cases. We did take a look at the enzymes, and this is just kind of for fun. This doesn't change a whole lot, but I found it interesting in the case that Bindi presented, where it jumped to 10,000 on day one. We looked at all grades, and there was no correlation between amylase and lipase initial presentation and grade of injury. That's kind of what we would expect because that seems to be well known. But if we look at their outcomes, if they ultimately end up with a duct defined as being intact versus not intact, their initial amylase and their initial lipase were higher, implying that they had a ductal injury. Now, if they went on from there, did they get a pseudocyst? The initial amylase and lipase was not predictive of pseudocyst formation, but the peak amylase lipase was predictive.
Okay, thank you very much.
Was predictive of developing a pseudocyst. So if ductal injury is predictive of pseudocyst, and ductal injury is more likely with high initial enzymes, and the pseudocyst develops later, and the peak amylase lipase are higher in those that develop a pseudocyst, there seems to be a bit of a rough correlation in outcome, but we don't have any cutoff levels.
Hi, I thought
There isn't any absolute number that you can use there for
triple American
patients, particularly if they come in with routine. So then finally, we just had a small set of patients.
I've got a bunch of long numbers. Let's see the authorization number. That would help. Or the award
comparisons.
So I've got the authorization number.
We see that they're
Not
the only one hearing this.
1D.
I think it's David
Mark,
Mooney.
can you mute David Mooney, please?
I know.
Okay, thanks.
I think we're good.
All right, so their demographic data was very similar. There wasn't really a higher degree of illness with the open group for the most part. And we see that their operative time ended up being similar. Everything else was comparable. And of the patients who ended up with a splenectomy, they were in the open group. And none of these were converted. Again, this is very small numbers, and this is a subset of data from centers that have laparoscopic experience. The complications were fairly minor in both groups, and both of the pancreatic leaks ended up being inconsequential that sealed up within a week. The postoperative course was similar between the two groups. And so we concluded that laparoscopy is feasible and at least equivalent to the open resection in selected patients. And so in summary, the distal pancreatectomy may be preferable with a ductal injury at this point. And initial enzymes are higher in those with ductal injury, peak are higher in those who are managed non-operatively who develop a pseudocyst. And the laparoscopic approach is at least equivalent to the open resection in the selected patient. But as I've said before in talking about this, even though it sounds intimidating when we talk about doing a laparoscopic distal pancreatectomy, usually the transection's been done for you, and then when you start to dissect it off the vein, using the ligature and just coming right along the vein there is actually a lot easier than open trying to get a hold of those little vessels and tie cut. So it's a pretty slick operation laparoscopically most of the time, and you can save the spleen pretty easily. It seems to me, I felt, having done it both ways, it's easier to make sure you save the splenic vessels when you do it laparoscopically. So from here, I think we do need to define the role of ERCP with stents across ductal injuries. And it's going to be important, as Bindi suggested, as we start thinking about prospective studies, is one, really narrowing our focus on those grade 2 to 3s and defining them just as grade 3s. I think most people would be able to say if you clearly don't have a ductal injury, you should be able to heal okay without an operation. And then once we get to that point that we really define the population that we're talking about that has a transection, has a ductal injury, who does better with an operation versus observation, whether that includes stent placement or not. And then with the long-term outcomes, looking at the problems of chronic pancreatic pain after observation, and then diabetes and malabsorption in those who end up with resection. That's it.
Sean, that was great. Thanks to both of you. It's slowly getting a little clearer maybe to some of us. I think the biggest challenge for me, and I'd like to kind of hear both of your comments on it, is I think there's pretty good data now that you've both shared with us that if there's truly a duct disruption, that a laparoscopic distal pancreatectomy would be a good and is probably the safest and best option. But I still struggle with how do you know that duct's disrupted? The one I was talking about a little earlier was related to we got an MRCP, and our MRCP group is great, and our radiologists are great, and they read it as normal. A few days later, his pain worsened. We ended up ultimately getting an ERCP and found a completely transected duct. By that point, he had tons of inflammation. We delayed. We ultimately took his pancreas out. But that's that challenge that I don't feel I have a good grasp on. How do I know when that duct's disrupted or not?
So I agree with Rich that an ERCP is the only way you're going to define duct disruption. An MRCP is going to have some of the same issues that a CT will, and the only way you're going to define it for sure is to put contrast in the duct. And then that leads to the whole next question is once you're there and you show that you have contrast extravasation, what's the role of getting a stent across it? And that the problem with that, especially moving forward with the idea that Bindi has in a prospective study, is the generalizability. We're obviously a high volume center, like many of you that are representing your centers there, and we lost our pediatric ERCPist. So now we're in a position that we have to get an MRCP before we can order an ERCP. That has to be facilitated at KU. Patient has to be transferred. Their pediatric surgeon and or gastroenterologist has to be there with the patient while the adult ERCPist does the ERCP. So it's logistically very difficult for us to get an ERCP now. And we typically only do them for a clear therapeutic reason. Those that have a common duct stone are now our patients who we send for ERCPs.
Hey, Sean and Bindi, we have a few questions. And the first one comes from Tara. And before I get to her question, because I had the exact same question. We talk about pyloromyotomy. And in a lot of places in Europe, they would do non-operative management. And yeah, you can do it, but it's just so easy to do the pyloromyotomy. I feel the same things here true with the pancreatectomy. If you go in right away, the operation's almost done for you. It's pretty easy to do with spleen preservation, even laparoscopically. I just think it's not that hard. However, the whole game changes if you wait a day or two. So really the question is not pancreatectomy versus non-operative management. It really, really matters when this happened. And that's Tara's question was the time between initial injury and presentation considered as a variable between the non-operative and resection groups? Given this was a retrospective review and this may have been a significant factor in the management decision. So can you address that, Sean?
Yeah, because we had patients that were up to a week out. So that wasn't the single deciding factor. And in our own experience here at Mercy, of those that we contributed, we had several patients that were 3 and 4 days out, where somebody managed them over the weekend, and then somebody the next week who's a bit more aggressive. We had 2 people in the group that were more aggressive with non-operative management, and so you would have a patient sit for 3 or 4 days, and then somebody would come on and say, well, I don't think this is going to get better. Look at that CT, and then end up doing the operation. You do see some saponification in the center portion there, but it doesn't make a huge amount of difference at 3 or 4 days. At least it hasn't in the cases that we've done. So I think you have enough of a window to make a rational decision. When that window ends, day 4, day 5, day 6, I don't have the answer to that, and I don't have data to share with that. But Tara is right that I think certainly across all centers, some of those patients would have ended up in a non-operative management category because of the way they got started. And so if somebody comes on day 3, the die's been cast, and then they say, well, forget it. This patient's sort of being managed non-operatively. You can call the other guy with your phone calls.
Let me ask you, Arbindi, Arbindi, did you want to comment? I saw you moving towards the mic.
Yeah, I did. To your point of it's easy enough to do the pancreatectomy, why don't we just do it? It's also easy enough to take your spleen out. Why don't we just do it for splenic injuries? We really don't know what the long-term outcome of taking out a part of a kid's pancreas is. There's no data on it. There's one study I've seen that maybe shows a 1-year outcome that a few patients did not have diabetes, but we don't know. I recently saw a paper of adult patients that have had Whipples before they, that have had, or was it distal pancreatectomy? Sorry, I don't remember. But essentially the whole theory of that if you only need 20% of your pancreas to remain functional long term is being refuted a little bit. And in children, that may be even worse. So I don't think that it's just because it's an easy enough operation to do is enough justification to just go ahead and do it.
So, Bindi, that's a great question. And that brought up the other question from Robert Acton, who said, has anyone here seen children get diabetes? I haven't. I've never. And I know that I hear your point. I'm not sure that OPSS is the same as diabetes. One, if you get it, you have a 50% mortality. The other one is not so bad. But I see your point, and your point is a good one. And I just want to know, do we know the numbers? How often do we see diabetes? Does it happen later on in adulthood that we're not recognizing?
So I would agree. I haven't seen it in my experience or in the literature that I've seen. But the question I think that always comes up, right, is how long do you need to follow them up before you know that answer? Mm-hmm. And I think that's something we're not generally very good at, is the long-term follow-up for those kids and figuring that out.
I think there's no answer to it right now, and I don't think it's going to come quickly because of what you just said. When we think about long-term outcomes, you look at how many people end up getting type 2 diabetes with a normal full 100% pancreas, and if these kids end up going on with similar lifestyles as the rest of the population, you would think that they would be at a disadvantage and end up potentially having more problems later. But regardless, you're looking at balancing two potential long-term outcomes that both could be pretty difficult to manage. And the one that really scares me with non-operative management is that patient that ends up with a pseudocyst and then ends up with the chronic pain and the chronic pancreatitis associated with pseudocysts. And then you put them on a horrible, horrible pathway very early in life. And the flip side of it is we don't know what we're doing to these patients 20 years later. And I think only the adult population could study it at this point, because if you take a healthy trauma path and take out their distal pancreas, I would expect them to do fine through the rest of their adolescence.
It's a great discussion. One quick question for you, Sean. Were there penetrating injuries in your study?
Yeah, we took those out of what you saw. Those were just the blunt injuries, and that was published separately. And it was a small enough series that there wasn't any really great point besides it just outlined the ways to manage it. Drainage, resection, depending on what was hit. But they weren't included in what we saw.
Great.
Well, great. Thank you both for those talks and that discussion. It was, I think, really useful for everyone.